Chapter 7, Foot and Ankle, Fracture Hardware Interoperative Assessment. Conflicts of interest. I'm a stockholder with Sonex Health and editor of a textbook for MSK Ultrasound and a lecturer for Expert Education. The first case was seen 6 weeks post-operatively. His surgery had been done elsewhere. It was a severe ankle fracture, and he had undergone an open reduction internal fixation. The wounds looked very good, but he had a numbness on the bottom of the heel, but not on the forefoot. When we started the ultrasound examination, we knew that one of the screws was out of the back of the tibia because of the x-ray. At first, we thought that the fluid we saw on the screw was a tenosynovitis, perhaps of flexor hallucis longus. On this lateral view, the white arrow indicates the screw that is sticking out of the back of the tibia, and the black arrow is showing the screw with the lowest point. This mortise view, it looks like the screw indicated by the white arrow has a tip that is somewhat more lateral, but we have to remember that the mortise view consists of an internal rotation of the tibia, so anything in the back of the tibia will look as if it were more lateral than it really is. In this transverse view, we can see that the screw, the repeated pattern to the left or medial side of the flexor hallucis, is not, in fact, on the flexor hallucis. On this long axis view, we can see the tip of the screw toward the left of the image, and there is fluid along the tip, which would be consistent with a tenosynovitis, but in this case it seems to be pulsatile. So we proceed with the Doppler, and we can see that the tenosynovitis is actually an artery and two veins at the tip of the screw. If we go short axis with our Doppler view, we can see that the screw actually passes underneath the artery, and it is the posterior tibial nerve behind the artery that is resting on the tip of the screw. So the conclusion that we can draw from this is that an ultrasound done just prior to closure would have indicated an immediate revision, in this case a replacement with a shorter screw. And our diagnosis confirmed that in the post-op period, sensation was restored to his heel. The second case is an adult female who is more than 2 years status post ORIF of a severe ankle fracture, and she comes in with pain at the posterior medial corner of her ankle, near the point indicated by the arrow, but more to the posterior side of the metal. Here is a static view with the metal plate, the bright white line to the right, and a somewhat less echogenic tendon to the left, being deformed by that metal. Here is a dynamic view with Doppler, and we can see an artifact on the side of the screw, but we see increased circulation within the tendon, indicating a tendinosis, and a deformity of it as the tendon appears to be splitting. If we follow the tendon more proximally, it becomes more echogenic and looks like a normal tendon. And just behind, or to the left, we see the flexor digitorum. And if we go even farther proximally, we see that this is a healthy tendon. The opposite ankle we can see in this image, which has been flipped to make it consistent with the left ankle, we can see the two echogenic tendons, the larger being the posterior tibial. If we go distal to the tip of the metal, we can see a fairly normal looking tendon. But then if we follow it to the back and up the back side of the plate, we can see it decrease in its echogenicity and deformed by the plate. The plate seems to split the tendon. So the conclusions from the second case is that if we had done an ultrasound prior to closure, we might have anticipated there would be a problem with the posterior tibial tendon. But unlike the first case, revision of this hardware would have been more difficult, as we would have had to move the plate. Probably what I would recommend in this case is following the tendons postoperatively and then removing the plate as soon as bone healing would allow it. So the summary of this presentation is that intraoperative post-ORIF but pre-closure ultrasound can direct in some cases immediate revision of the hardware or planning for a removal of the hardware earlier than one usually would do.